So, before you walk into that doctor's office and nod yes to every test on that clipboard, watch this first. Because there are 5 medical tests that millions of Americans over 65 are routinely offered every single year. And what your doctor may not have time to tell you, what the U.S. Preventive Services Task Force, the American Geriatric Society, and researchers at Johns Hopkins have quietly been publishing for years, is that for some older adults, these tests carry real risks that can outweigh the benefits. I'm not saying avoid your doctor. I'm saying go in informed. Ask the right questions. Because a test is not automatically the right answer just because it's offered. And knowing the difference could protect you from procedures, medications, and complications you never needed in the first place. Here's something the medical system doesn't advertise. In 2012, the American Board of Internal Medicine launched a major initiative called Choosing Wisely. It brought together over 80 medical specialty societies to identify tests and treatments that were being overused, things that, for specific patient populations, offered little benefit and real potential for harm. The lists they published were stunning. And the patients most affected? Older adults. People over 65. People over 75. Because as we age, our bodies respond differently to interventions. A biopsy that causes minimal stress for a 40-year-old can carry serious complication risks for a 72-year-old. A medication triggered by a borderline test result in a 68-year-old can cause falls, kidney damage, or dangerous drug interactions. The problem isn't the tests themselves. The problem is applying them without asking whether they are appropriate for your age, your health history, and your actual goals. So let's go through the 5 tests, what they are, who genuinely benefits, and what question you should ask your doctor before agreeing. Test number 1. Annual EKG or resting cardiac stress test for low-risk patients. If you have no symptoms, no chest pain, no shortness of breath, no irregular heartbeat, and you have no significant history of heart disease, the U.S. Preventive Services Task Force has stated that routine EKG screening for low-risk adults offers no proven benefit in reducing heart attacks or cardiovascular death. Yet it remains commonly ordered as part of annual checkups for older patients. The concern is not the EKG itself, it's what happens next. An abnormal reading in an otherwise healthy person can set off a cascade of follow-up tests, including invasive cardiac catheterization, which carries its own procedural risks. A 2013 study published in JAMA Internal Medicine found that incidental findings from routine cardiac testing led to unnecessary downstream procedures in a significant subset of patients, particularly those over 65. Your question, do I have symptoms or risk factors that make this test appropriate for me right now, or is this being done routinely? Test number 2. PSA screening for prostate cancer in men over 70. Prostate-specific antigen testing is one of the most debated tests in modern medicine. The U.S. Preventive Services Task Force recommends against PSA-based screening for prostate cancer in men 70 and older. The reason is biologically important. Prostate cancer in older men is frequently slow-growing, often described by oncologists as something a man will die with, not from. But an elevated PSA can trigger biopsies, which carry risks of infection and bleeding, and diagnoses that lead to treatments, surgery, radiation, hormone therapy, each carrying serious side effects including incontinence and erectile dysfunction. A landmark 20-year follow-up study published in the New England Journal of Medicine in 2012 found that many men treated for early-stage prostate cancer detected by PSA screening experienced significant quality-of-life reductions from treatment without meaningful survival benefit. This is not about avoiding cancer care if you have symptoms. It is about asking whether a routine screening test is going to help you specifically. Your question, given my age and overall health, what is the actual likelihood that finding something on this test will improve my life expectancy or quality of life? If this is helping you think differently about your health conversations, hit like right now and subscribe. Because the next 2 tests are ones that almost no one talks about, and they may surprise you. Test number 3. Annual pelvic exams and pap smears in women over 65. Major medical organizations including the American College of Obstetricians and Gynecologists and the U.S. Preventive Services Task Force agree that women over 65 who have had adequate prior normal screenings and are not at high risk do not need continued Pap smear testing. Cervical cancer develops slowly, and decades of normal results effectively rule out meaningful risk going forward. Yet surveys consistently show that large numbers of women in this age group continue receiving these exams routinely, without the discussion about whether they are still indicated. The concern here is both physical, vaginal atrophy in older women can make pelvic examinations genuinely painful, and medical, since false positives can trigger unnecessary follow-up procedures, including cervical biopsies that carry risk of bleeding and infection. Your question: based on my screening history, do guidelines still recommend this test for someone my age? Test number 4. Routine annual bone density scans beyond established intervals. DEXA scans, bone density tests, are valuable tools for diagnosing osteoporosis and assessing fracture risk. However, the American College of Physicians published guidelines noting that repeat DEXA scanning at intervals shorter than every 2 years rarely changes clinical decisions for most patients. In women with normal or mildly low bone density who are not on treatment, annual or even biennial scanning adds little meaningful information. Yet many older patients receive them yearly. The risk here is indirect. If a borderline result triggers medications, particularly bisphosphonates, the most common osteoporosis drugs, older patients face side effects including gastrointestinal problems and, rarely, a paradoxical condition called atypical femoral fracture, where the very bones being treated break more easily after long-term drug use. A 2011 study published in the New England Journal of Medicine specifically found that in postmenopausal women with normal or mildly low bone density, the progression to osteoporosis requiring treatment was very low over a 15-year period, meaning frequent rescreening in this group provides little clinical value. Your question: how often do my results actually warrant retesting? And would a shorter interval change my treatment plan? Test number 5. Tight blood sugar control and A1C testing targeting very low levels in older adults with type 2 diabetes. This one is critically misunderstood. Intensive blood sugar control, pushing A1C levels very low, is a well-established goal for younger people with diabetes to prevent long-term complications. But for older adults, particularly those over 75, the American Geriatrics Society, the American Diabetes Association, and the Endocrine Society have all published guidance stating that less aggressive A1C targets are often more appropriate. Because the long-term benefits of preventing complications like kidney disease take years to materialize. In an older adult with a shorter time horizon, those benefits may not apply. Meanwhile, the risks of hypoglycemia, dangerously low blood sugar from overly tight control, in older patients are immediate and serious. Hypoglycemia in seniors causes falls, fractures, car accidents, and hospitalizations. It is a leading cause of preventable emergency room visits in adults over 65. A 2008 trial called ACCORD, funded by the National Heart, Lung, and Blood Institute, was actually stopped early because patients in the intensive blood sugar control group had a higher rate of death than those in the standard control group. Your question: given my age and overall health, what A1C target is actually right for me, and are we avoiding the real risk of low blood sugar? Here is the single most powerful thing you can take from this video. Going to the doctor is not passive. You are not required to agree to every test, every screening, every intervention, simply because it was mentioned. Doctors are working within systems that often default to more testing, more diagnosis, more treatment. Your job is to ask whether more is actually right for you right now based on your age, your history, and your goals. The Choosing Wisely initiative exists because the medical community itself recognized this problem. Use it. You can search choosingwisely.org for their complete list of tests and treatments they recommend discussing more carefully before agreeing to. You deserve a healthcare system that works for you, not one you simply move through. Ask the questions. Be the patient who walks out more informed than when they walked in. That is not being difficult. That is being smart. If this video helped you, share it with someone you love who is navigating their own healthcare decisions. And subscribe, because next, we're covering what the research actually says about foods and your circulation. That one is going to be just as eye-opening.